Good evening. Thank you all for having me here. My name is Chris Broderick. I'm coming to you from Research Triangle Park, North Carolina. I want to tell you guys a little bit about myself. My colleague, Dr. Sam Fagg, will also be joining us on this presentation today. My background for the past 10 years has been in cell and tissue processing with various human tissue types. And most recently, at Maricris Therapeutics, we've been leading projects with postpartum tissues that have applications in chronic wound healing, organ transplant applications, and various other inflammatory diseases. Sam's background is a cell biologist. He works with the University of Texas Medical Branch, and we're here to talk to you today about the therapeutic value of a product called Dermacyte and its regenerative alternative for acute and chronic wounds and that are refractory to traditional wound care. The objectives of this presentation today will be to look at the disease burden of diabetes in India. We'll also talk about the pharmacoeconomics, the advantages of using an advanced wound care product such as Dermacyte and what that does to the chronic wound populations that may be undergoing standard treatments. To better understand the product's efficacy, the mechanisms of action, the safety, we're going to try to give you a basic explanation and dive into some of the cell signaling properties that are preserved in the Dermacyte product as it relates to wound care applications. We're also going to communicate the opportunities that you may see fit to use Dermacyte in your clinic or your hospital institution, and treatment plans that you must consider for your patients, and certain techniques that must be considered when applying the product. The disease burden and the patient morbidity of the diabetic foot ulcers in India is a significant challenge, and it's a significant problem for the country. We have here in the United States also have a significant challenge with diabetes and have various products in advanced wound care and regenerative biomaterials to treat diabetic ulcers and venous leg ulcers. So looking at the facts in India, it's very prevalent disease that affects 52 million people. 25% of individuals in India will develop a foot ulcer. A lot of these foot ulcers will be ongoing for 1 to 3 years and oftentimes will lead to amputations. A publication in 2017 showed that there was 40,000 amputations per year in India with an 11.6% prevalence rate. And around the globe, there's an amputation that takes place almost every 30 seconds due to diabetes. It's an astounding number, and we have to ask ourselves, what can we do about it to improve the quality of life of patients that are facing these amputations? And if you think about quality of life and what does that mean to a patient that may be facing an amputation, it leads to a significant reduction in their work, their social activity, their emotion, their ability to bring income in for their families. It's a very long-term effect. And on this slide, graphically, what I want to show you guys is a study that was published, I believe this was out of Britain in 2006. This looks at the unhealed and healed diabetic foot ulcers and the impact that patients have in various elements that were studied for healed and unhealed foot ulcers. So the blue represents the healed diabetic foot ulcers, and what this will show you is that there is a statistically significant impact to the patient's limitations on their activity. So a lot of activity will be significantly reduced for a patient that has an unhealed diabetic foot ulcer. There'll be a serious reduction in their desire to accomplish uh, their goals and objectives in life. Major limitations will be statistically proven that major limitations to work activity and pain was not major difference in the healed versus the unhealed. But there you can see from this graph that there's major statistical unhealed issues related to diabetic foot ulcers. Some other additional facts that were published in this study showed that there was 155 times elevated risk of an amputation when a diabetic foot ulcer is infected. So an infected diabetic foot ulcer, you have a significantly high risk that the patient will face an amputation. And typically, with an ischemic diabetic foot ulcer, within 5 years, 45 to 55% of the patients will die. So again, these are just astounding numbers, and we have to think about what treatment options are out there to both work toward preventing deaths and improving the quality of life of patients. So just going back over the burden of diabetes in India, India spends more than any other country in the world on treating diabetes, or diabetic foot ulcers, that is. A big challenge for patients is that it takes almost 70 months of average income. So an average patient or an average income in India, it's going to take almost 70 months for that patient just to pay for the standard of care. That standard of care may be ongoing for 2 years to 3 years, and then that patient may face an amputation. So again, 25%, we talked about this a few slides ago, 25% of the patients that develop diabetic foot ulcers, 50% of them will become infected. And of that 50%, 20% of those will need an amputation, and they'll be hospitalized. So there's a significant cost impact that leads to a patient being burdened for paying for those costs in India. And there's significant times to heal the wound in India. Up to 62 weeks is what was shown in this study. 50% of Indian patients who suffer from an amputation will require a second amputation within 2 years. And then that's just an astounding number to think about, having to have a second limb amputated following a first limb amputation. So looking at the cost in American dollars, the total cost of a limb amputation, the first limb, may cost close to $7,000. And I don't know how that resonates with you all, but this data was pulled out of a publication that was done about 10 years ago. So I'm not sure if that, I would assume that cost may have gone up now. So the goal that we feel that we can impact with an advanced regenerative technology is there's certainly going to be some upfront cost, but we feel that we can mitigate those costs, reduce hospitalization rates, which ultimately lead to reduced costs for the patient. And the patients will need to know that they have an advanced option to consider that may be relatively close with respect to the cost of an amputation, but that patient may have an opportunity to have a significant gain in their quality of life. Again, we know that these patients' lives are impacted by a significant cost burden by taking up to almost 70 months of an average income to pay for the care that they would receive for a ischemic diabetic foot ulcer. And we know this is a major financial impact to the country, with almost 40,000 amputations occurring a year. And we think using advanced technologies such as dermacyte, this can be prevented, and we can have a significant impact on this amputation number. And we hope to be able to drive this down by introducing this advanced technology into the India market. Next, I want to talk a little bit about the pharmacoeconomics of advanced wound therapy and how it improves patients' quality of lives for receiving an advanced therapy. So in a study that was done, this dates back some time ago with an advanced wound care therapy product, and what was defined as an advanced wound care therapy product in this study was a uh, a, a regenerative tissue graft, and I use the word regenerative by suggesting that there's bioactive proteins and cell signaling molecules. And what this study showed that in comparison to a standard of care, which uses a traditional offloading, debridement, and moist dressing and ongoing visits to the clinic, that there was a 12% decrease in annual hospitalization cost with advanced therapy. In addition, there was 24% more ulcer-free days with an advanced therapy, 67% less time with infections, and 63% lower risk of amputation. And so this should really demonstrate in this study that was conducted on about 30 patients that advanced wound therapy is cost effective over time, and it does reduce amputation risk significantly. So this graphic is intended to show the concept of the quality of life that is gained by receiving treatment of an advanced wound care therapy, and this was published in a British medical bulletin. And so what you can see on the lower line is that without treatment, the quality of life, which is represented on the y-axis, is both significantly reduced and leads to a quicker death when not receiving treatment than the second line, which shows you a much higher quality of life for an extended period of time, and therefore you're going to get many more quality of life years that are gained from treating a patient with an advanced wound care therapy. So in summary, from a quality of life and what that cost entails to the patient and to the country and to the healthcare system, there's going to be decreased infection rates, there's going to be decreased hospitalization, there's going to be a major decrease in amputation risk, and there's going to be a decrease in the open ulcers that a patient has to battle with when they have diabetes. And this all leads to an increased quality of life, and it leads to increased work and social contributions. And so a product that we want to educate you on a little bit more today is Dermacyte, which is rich in cell signaling cytokines, growth factors, and has been shown to improve healing and decrease immunogenicity, and it should be considered as a treatment option. And patients should be well informed of their options for advanced therapies that may present a cost burden initially, but should have the opportunity to take the consideration for what it means to their family and their quality of life. So I'm going to turn the presentation over to our lead scientist, Dr. Sam Fagg, who's presenting today from his university institution, and he's going to talk to you about the basics of Dermacyte.
Okay, thank you very much. Hydrated amniotic tissue graft. It's been processed to preserve proteins, extracellular matrix, and cellular components of the amnion for use in the chronic and acute wounds and burns. And I'd like to add too that we rapidly process this in a very minimal way in order to preserve these proteins, and have done some analysis that indicates that they're still present in our final product and still bioactive. Okay, so amniotic tissue has a very long history dating back to the early 1900s, where Davis introduced the first use as a skin graft. About mid-century 1900s, there were reports of amniotic membrane used as a temporary biological dressing in the coverage of burns. And so very early history as skin graft and burns and wound treatment. Then in the mid-90s, amniotic membrane was introduced for ophthalmic use, and really more modern-day techniques, including aseptic recovery, cryopreservation, dehydration, etc., made amniotic allografts increasingly popular and safe. Okay, so just a brief overview of the anatomy of the amnion and amniotic fluid. So these are found within the placenta, and you can see that the amnion is on the left-hand side of the figure there. The amnion is the blue outer covering of the amniotic sac, and within that is amniotic fluid. And so this surrounds the fetus and provides a protective layer, and the amniotic fluid actually provides some nourishment as well for the fetus. On the right side, then we have a cross-section view of the amnion. The upper layer is the epithelial layer. These have amniotic epithelial cells attached to them, and this is located on this luminal surface where you'll find the amniotic fluid as well. Then below that epithelium, there are several layers of membrane. There's a basement membrane layer, then a compact layer, fibroblast layer, and then a spongy layer. And then below that, you'll find the chorion. But really what I want to highlight here is that within these different layers, you find abundant types of collagen and extracellular matrix proteins. So these provide a very nice barrier function in utero, and as you'll see for other applications that we're using. Okay, so the primary functions of amnion and amniotic fluid in utero play both structural and non-structural roles. So the structural functions are to cover and protect the fetus, retain the amniotic fluid within, which the fluid actually provides lubrication and cushion to the fetus. And also the membrane selectively allows molecules to pass from the maternal to the fetal side. Then the non-structural functions, or we classify these into biological functions. So they reduce inflammation, reduce scarring. Actually in utero, the fetus can completely heal from wounds without scarring, which is very interesting, and there's been some basic science research done to dissect the mechanisms by which this occurs. There's also an anti-angiogenic function. Additionally and similarly promotes wound repair and healing and provides nourishment to the fetus. Okay, so we've done some analysis of the cytokines that we find in both the amniotic membrane dermocyte product and the flowable wound matrix product. We've done a multiplex ELISA, which is an assay that identifies at the same time hundreds of different proteins and cytokines present in these two products. And in order to not overwhelm you, we've just selected here several growth factors and anti-inflammatory cytokines. And we find high levels of bone morphogenetic protein 7, BMP7, epidermal growth factor, that's EGF, fibroblast growth factor 7, that's FGF, and then HGF as well, hepatocyte growth factor. On the right side, we're highlighting some anti-inflammatory cytokines. I'd like to just point out TIMP1 and 2. These are tissue inhibitor of metalloproteinase proteins, and so these actually inhibit pro-inflammatory signaling in the extracellular as well as intracellular environment. And so we found that these are highly present and enriched in both the membrane product, dermocyte, and the flowable matrix. Okay, so what does that mean? I mean, how is this going to help a patient? And so here I'm just summarizing a few clinical findings that have used amniotic allograft which indicate that there's very high efficacy in these wound studies. And so I've broken this down as to giving multiple applications or single applications of a product, because as you're aware, a patient may or may not be able to afford a single application, much less multiple applications. However, what we find is with multiple applications, this is the most effective by far. The reports that I've pulled from several review articles and other clinical studies indicate that 100% healing is reported with multiple applications. And what do I mean by multiple applications? Just more than one during the healing process. And so I've further broken this down into either a weekly or bi-weekly application. And so with the weekly application, what you find is a median time to heal of about 2.5 weeks. With a bi-weekly application, meaning application every 2 weeks, what you see is about four weeks for time to heal. And again, these multiple applications report 100% healing in all of the studies that I was able to access here. Then single application, this is much more preferable over standard of care, and still, statistically significantly indicate that this is a much more successful type of application. So with the single application of amniotic membrane alone, we find there's an 83% healing rate, and the time to heal median is about 11.8 weeks. However, if you do a single application of a combinatorial therapy using amniotic membrane and amniotic fluid on the wound, you find that the healing rate increases to 90%, and the median time to heal is reduced to about 10.5 weeks. And over here on the right, I'm just showing you an example of an amniotic membrane allograft in the clinician's hand there, and that's a diabetic foot ulcer on the right. The bottom figure shows 8 weeks later that this foot ulcer is completely healed. And this is just a single example, and this was pulled from one of the single application studies, I should add. So in summary, we find very, very high efficacy, significantly improved over standard of care with the amniotic allografts, both the membrane product and the flowable fluid product. Okay, so just a real quick overview of the safety and quality assurance we have using these products. So Dermacyte comes from informed and consented mothers only undergoing elective cesarean birth. There is extensive screening, which eliminates any risky donors. We perform serological testing with the FDA-approved tests performed on every qualified donor to screen for HIV, hepatitis B virus, hepatitis C, as well as syphilis. Okay, so and our both fluid and membrane products processed at an FDA-registered and inspected laboratory under good tissue practices as defined by the FDA. We do terminal sterilization.
Hey Sam, can you hear me, Sam?
Process.
Are you able to hear me? Are you able to hear me? So they're saying we just, all of a sudden there was a break in the audio when we went to this manufacturing slide. Hold on one second.
Okay.
And so what's going on, just so you know, is you're actually on speaker talking through my computer here.
Oh wow. Okay.
Let's see.
That audio probably isn't great.
No, they said it was great. They said it was loud and clear.
Okay.
And initially it wasn't coming through your computer. Sorry.
Yeah, this is kind of strange because I can't see anything, or
Yeah, it's.
I don't know if anyone can hear me, or I don't know if I'm advancing the slides really.
Yeah, you are. You have been advancing, so everything's
Okay.
been looking good. I just don't think we can see their end.
Yeah. Okay. Yeah, I mean, I think that's my last slide anyway. Yeah.
So I'm going to try to take over, Sam, and talk a little bit about the manufacturing and quality assurance. Um,
Sounds good.
I want to make sure that these guys can hear me though before I talk. So if you guys can let me know if you're able to hear me, so I can talk a little bit more about the manufacturing. Okay, it sounds like they're able to hear me, and I'll talk, Sam, and if we have some questions, maybe you can jump in as well. But just let me make sure we back up a little bit and talk about the donor safety and quality assurance. So we're dealing with postpartum tissues that are collected at cesarean section births, and so there's certainly a very stringent process. It's actually about a 50-page risk analysis that's performed by a trained technician that's within the hospital that facilitates obtaining an informed consent that's signed by the birthing mother who has a scheduled cesarean section. So these extensive screening questionnaires, like I said, it's about a 50-page questionnaire that looks at genetic diseases from direct relatives, also looks at behavioral history, IV drug use, various lifestyle elements are all taken into consideration to reduce the risk of any donor safety that might be a concern. And these questionnaires are not only required by the FDA, but by one of the most stringent organizations here in the United States, referred to as the American Association of Tissue Banks. And a blood sample is also obtained at the birth that's sent to a US FDA approved lab that tests for a panel of infectious diseases. And you can see below, HIV antibodies are tested for, hepatitis B, hepatitis C, and syphilis. Depending on the donor, there may be other tests that are performed, but this is all done through, in addition to ruling out diseases, by having multiple medical directors assess the medical charts of the birthing mother, as well as the infant discharge records from the hospital. So all of this is assessed during the procurement process, which is quite time consuming. But going back to the manufacturing, safety, and quality assurance, this product not only was developed to advance over what other allograft tissues are out there, but this is done at a US FDA facility. It's done under good tissue practices and GMP, which is defined within the US FDA regulations. There's gamma sterilization that's performed on the product. So following the packaging of the product, that goes through a process of removing any blood, any other debris, and separating the chorionic tissue layer. Following that process, the product is packaged, and then it receives a sterilization dose, which has been validated to assure that it has a sterilization assurance level of 10 to the negative 6. The batch records, so all the production records are reviewed by a quality assurance director. There's a scientific director that reviews the processing records and the donor records, and there's also a licensed medical director that reviews these records to ensure that maximum patient safety is adhered to throughout the entire process, and those 3 reviewers are required to sign off on the product. There are no serious adverse events that have ever been reported from the use of human amniotic tissues. And so the message here is we want you guys to have the most assurance that this product is safe and the highest level of quality assurance is put into this product. So if you're following along, Sam, I'm going to be talking a little bit about the applications in wound care and go over the treatment technique that's required for applying amniotic tissue. And you will find this in the brochure, the Practical Considerations brochure. So on this slide, I'm going to highlight a section of the Practical Considerations brochure. You can see from the images here, A, B, C, and D, there's a debridement process that's required. So a sharp debridement is necessary where there's good blood flow into the wound bed. This allows for the patient's cells to interact with the protein signals that are preserved in the dermacyte product. So following the debridement of a wound, the dermacyte product is a dehydrated product, so it's a dry product that gets laid directly onto the wound bed. Once that product absorbs the bodily fluids, the blood in that wound bed, it'll naturally just conform to the shape of the wound bed. On top of that dermacyte product, there's going to be the placement of a non-adherent material, followed by a moisture retentive dressing, and followed by a compression dressing. So on this slide, I highlight that. You can see a material that's commonly used here is Adaptec Touch. It allows any exudate to flow out of the wound and then become absorbed in the new gel, which is a moisture retentive dressing. So these dressings can be changed, and these may be questions that you guys have. We don't want to disturb the dermacyte product. So as long as dermacyte is staying in place, depending on the exudate that's being secreted from the wound bed, it may require changing the moisture retentive layer and the compressive dressing, and the patient can be instructed to do this at home. And they need to be very careful, and patient compliance is very important with this product being effective, but they need to be very careful to not disturb the amniotic membrane. And we recommend leaving that non-adherent dressing in place until they're in a clinic or in a professional setting where a provider can remove that adherent dressing and replace the dermacyte product if they're going through follow-up treatments. Typically that treatment is done every 2 weeks, give or take, and so cost is something that certainly needs to be considered here. And as Sam pointed out in prior slides, you can get close to 90% healing using dermacyte as a standalone, but one of the products that we'll be introducing behind our dermacyte structural material is going to be a dermacyte flowable material, and that's where we can get 90% healing by using them in combination. There was a video here that I wanted to show you guys, and unfortunately it wouldn't render into the presentation. So it was about a 10-minute video, so I'm just going to talk through it and be really quick, but ultimately it goes back through the images, which were the debridement steps, which can be a long process, but it really does require a sharp debridement. It shows the application of the amniotic membrane, which was literally just laying the product down into the wound bed, followed by the series of dressings that are applied with quite a bit of wrapping that goes around the extremity that's being treated. So apologies on the video not being available. I want to show some literature and some poster presentations that have been done around the amniotic tissues placement in a variety of different chronic wounds. In this image, you'll see a non-healing foot ulcer. This patient had battled this for well over a couple of years, actually, and this non-healing wound, after 57 days in the utilization of the amniotic tissue, showed significant progress, which you can see at day 60 was very. They've defined this as a closed wound bed. So very, very advanced and enhanced healing you can see from these images I'm showing you guys. And so this is a 45-week period where we captured pictures at the initial treatment. So there was a debridement. You could see the entire bone and the osteomyelitis this patient had, which was very severe. This was done at 3-week intervals, at least for the first treatment. So on week 3, they did another debridement, removing the product and then applying a second product. And then going out 9 weeks, you can see excellent granulation within that wound bed. Going out 6 months and 45 weeks, you now have wound closure. It's just amazing the progress that can be made using this product. So here's another diabetic heel fissure that shows complete closure within 13 days. Dr. Keith Goss, I apologize for this, but due to the software requirements to present, Dr. Goss was not ready, but I'll just kind of give a little bit of our experience in amniotic tissue's impact to the Indian Health Service. So this is the Native American Indian population, which is probably the most challenging diabetic population that we have here in the United States. And not only is it the most challenging patient population with one of the largest disease burdens, but these patients are actually 3 times more likely to develop diabetes than the American population. And these studies have been showed, and this is what Dr. Goss was going to talk about. They're 3 times as likely to develop an ulceration and 3 times as likely to require amputation due to that result, that ulceration, as well as 3 times likely to die from the amputation. So this patient population is a unique patient population here in the United States that is funded through a very low-funded government program that we have here, and so the amputation costs were very significant. And Dr. Goss was the director of the wound care division. He's a licensed podiatrist, and in the implementation of advanced wound care, I've just taken the opportunity to present some of their data that they've analyzed across the numerous hospitals that treat specifically this patient population. They've had a 73% decrease in amputations, and this isn't just from the application of the product, but it's just advanced wound care therapy altogether. They've done 7,000 vascular surgeries in 3 years implementing this advanced wound care, with 1 to 8 vascular surgeons dedicated to limb preservation at each facility that he's affiliated with. We'd like to field any questions and try to address that, so we have some time. If you guys have questions for us, we'd love to hear what questions we could answer, but I really appreciate everyone's time today and the opportunity to present Dermacyte and some of the facts we've presented. I don't know if how many we still have in the room, but Sam, I don't know. We'd like to maybe take a chance at you just going back to talk about what is the exact mechanism of action of Dermacyte. I think that was somewhat covered, but if just to give any clarification there.
Yeah, sure. So the mechanism, there are multiple mechanisms of action of Dermacyte, actually, and I guess if we were to jump back to slides of the protein analysis present here, and while this is the analysis of the data is showing the flowable wound matrix product, like I said, we did the same analysis using the Dermacyte membrane patch and found that many of these pro-growth factors and anti-inflammatory cytokines were enriched in the product, as well as some chemokines. And chemokines, as you probably know, are chemo-attractant molecules that actually will attract different cell types of the immune system and other types of cells such as of that nature to a certain region, which can then promote remodeling, promote removal of necrotic tissue, and that sort of thing. So we think there's a multi-step process behind the mechanism of action of healing that involves recruitment of cells to remodel the tissue, removing dead necrotic cells, and then promoting new reepithelialization of the tissue and growth of new cells. So it's a multi-step process, and while we don't know precisely every step at which there's promoting of growth and inhibiting of infection, we do know kind of an overview of it, and I hope that's painted the overview picture for you.
Yeah, thanks, Sam. Well, thank you all for your time today, and if there are any questions, please address them on the forms that we've passed out for getting some feedback from you all from the presentation today. Thank you so much.